Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hello, this is Dr. Nick Biasotto. I'm the host of the Medical Society of Delaware podcast, Delaware Healthcare Reality. Today we have two guests. Their bios are coming. One of the guests you've heard before because she's our announcer for all of our podcasts, and that's Rhoads. And the other guest is Dr. Mike Bradley, a retired family physician from Dover. The bios are such. In 1994, Mike Bradley, DO, was elected as the first osteopathic physician in history to the president of the AMA State Medical Society. In addition to serving as MSD's president, Dr. Bradley has served the Medical Society of Delaware as a member of the House of Delegates, Board of Trustees, and numerous committees. He also was the first osteopathic physician elected to the AMA House of Delegates and served as a Delaware delegate for 15 years. He has participated as a member of 3 reference committees in that function. In addition, Dr. Bradley has been president of the Board of Medical Network Management Services of Delaware, i.e. MedNet, since its inception in 1996, a wholly owned subsidiary of the Society, assisting physicians in forming managed care networks. He made a presentation to Cosmo at its 1997 annual meeting on PO development in our state and was the commencement speaker to the 1997 graduating class of Chicago College of Osteopathic Medicine. He founded the Department of Family Medicine at Bay Health Kent campus in 1983 and a founding partner of Dover Family Physicians. Dr. Bradley has been on the board of directors to Kent Medical Care, Inc., an urgent care center, and has been both chairman and of the Department of Family Practice and a member of the board of directors at Bay Health Kent campus in Dover, Delaware. Dr. Bradley has been an active member of the Kent County Medical Society, American Academy of Family Physicians, Delaware Chapter, American Osteopathic Association, and the Society of U.S. Army Flight Surgeons. He served 5 years active duty in the U.S. Army, leaving at the rank of major before settling into practice in Dover. Dr. Bradley has a keen understanding of the need for establishing collaborative and dynamic directions for the future of the Federation of Medicine. He served on several committees of the Delaware Healthcare Commission and continues to serve on the Primary Care Subcommittee of the Medical Society of Delaware and the Primary Care Reform Collaboration of the state. Dr. Mike Bradley retired from the Dover Family Physicians in 2021 after he served his patients for over 38 years. He is enjoying his retirement, spending time with his wife, children, and grandkids. He recently became president of his HOA in Magnolia, Delaware. Welcome, Mike. Our second guest is Rhoads. You will recognize her voice as being the introductory voice of our podcast. Lorianne joined the Medical Society of Delaware in 2008. She has served in positions that include operations management, physician relations director, manager of MedNet, and now serves as Medical Society's Director of Health System Innovation. Lorianne has a background in practice management and has a board certification from the American College of Medical Practice Executives. She is also certified in healthcare practice transformation. Welcome, Lori. Okay, guys. Today we're talking about MedNet. Give me a little bit of information about MedNet, would you please, Mike?
Hey, it's great to be here, Nick.
Great to have you.
Yeah, MedNet was formed way back in 1992 after the Clinton Health Initiative failed. The Medical Society started looking at ways that we could help mainly independent physicians in practice with the managed care environment. You know, at that time, the HMOs were expanding and getting more and more control over life in our practice. And after about 2 years study, we came up with MedNet, which is a physician-owned and physician-led management services company. It's a subsidiary of the Medical Society of Delaware, and has been supported by the Medical Society. We have 4 independent parts of MedNet, one in Newcastle County, one in Middle Kent County, one in Eastern Sussex, and one in Lower Delaware. These independent physician organizations manage their local physicians and other clinicians that we've signed up over the years, and they report to our medical board. One of the interesting things is that MedNet can go out as a messenger model and gain good contracts for physicians in practice. And because of that, we have over 1,300 physicians and other clinicians currently in our network. We're at the highest level that we've ever been.
Mm-hmm.
So,
I'm president of the Newcastle County PO.
That's correct. I was president of the Central Delaware PO for many, many years. Mm-hmm. And recently, a couple years ago, turned that over to Dr. Fletcher, one of my younger partners at Dover Family. This year, interestingly, we're going to be merging the 3 lower physician organizations into one organization, the Southern Delaware Physicians Organization. It makes more sense. It's going to streamline our ability to react quickly to contracting and helping our membership.
So your services include, helping practices get higher reimbursement for fee-for-services. That's one. And provide Delaware payers with a network statewide physicians and clinicians, including primary care and also specialties. Mm-hmm. When everybody can join in the field of medicine that are physicians, correct?
Any physician is open to join. The good thing about our contracts are they're all opt-in, meaning that the physician can pick and choose the contracts that we have, ones that he likes to join, ones that he doesn't want to join. He's not bound by every contract that we sign. Currently, I think we have over 10 contracts with various insurance payers. When the state went to a managed Medicaid program probably 15 years ago, we provided the main network of physicians for the state. We were responsive. Probably within a few months, we were able to provide them with a Medicaid network of physicians. So we had very good success with our Medicaid products to the point where we are financially doing very well, and we returned over $1 million to our primary care practices from shared savings with the Medicaid insurers. And we probably would have earned more, except during COVID, there weren't as many patients going to physicians' offices and such. But we probably saved the state over $5 million in Medicaid money during that period of time.
Nice. This all boils down to helping the doctors meet quality measures as an incentive for increased reimbursement. And with quality measures comes cost containment. So that's very good. We're all trained in that particular area on how to do that so that we can qualify for reimbursement increases. Mm-hmm. I have another question. So MedNet supports services to enhance reimbursement for practices, particularly primary care, obviously because we're all suffering. Primary care is probably one of the lowest on the totem poles when it comes to reimbursement. So it's very difficult to be in an independent practice anymore. It improves quality care for the patients of Delaware by monitoring certain important bullet points in a person's health, and it improves access to care for patients and providing a cost-effective measures for our state. That's all very good. Mike, do you have any more to add in that particular instance?
Yeah, well, one of the things we did with MedNet a few years ago was basic practice transformation, bringing a practice who was still doing things on paper into the computer age and helping them to meet some of these new quality standards that the various insurance companies, including Medicare and Medicaid, are coming out with. The future of payment reform is going to be moving probably from a fee-for-service type of payment to a prospective payment, and including more quality measures that can be easily quantified. There's a lot of quality measures, and we'll get into that, but we're able to help train office staff and to bring these good contracts that are all moving toward quality-based care. Your independent primary care physicians, that's part of their training. They learn how to take care of their patients in a cost-effective way without wasting it on care that's not absolutely necessary.
I see. That's very good, and I think, this has helped physicians as well as the patients of these physicians improve their medical care. Now, I would like to take a break at this point, and we're going to bring in Lorianne Rhoads and talk to us about value-based contracting. So we'll be back.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
We're back from our break, but before we go into value-based contracting with Lorianne, there are many things such as managing credentialing with payers. You know what a hassle that is for an independent doctor to do all the paperwork to get credentialed through insurance companies and satisfy that insurance companies. MedNet does that for you. And if ever there are any significant issues that many other physicians or physicians in our system are having problems with the insurer, whatever that may be, we can take it through Lorianne Rhoads, who can then act on our behalf to discuss this with the payers and resolve the problems. Correct?
That's right, Dr. Biasotto. Thank you for having me as part of the podcast today.
Okay.
That is one of the main selling points for being a member of MedNet. Practices really just don't have time to deal with the insurance companies and all the different sets of paperwork to onboard new practitioners or to make changes within their practice. One call to our company, MedNet, will satisfy all of that. And like you said, if there's claims issues or whatever may be happening in the office, we can help be that middleman and take the pressure off the practices there. So I think that's something that the physicians, practice managers, credentialing folks, billing managers all really appreciate.
Fantastic benefit to join MedNet in my mind. That alone, let all the other things that they do. All right, let's move into value-based contracting. Talk to me about what is it?
As Dr. Bradley alluded to, our healthcare industry is moving away from fee-for-service environment. And for those that don't know what fee-for-service means, that's paying for a service that's delivered. So think about your auto shop person. You take your car to the mechanic and you pay them for whatever service they provide. That's what environment we are in now in the physician practice setting. You go in, you have a service performed, and they're being paid for that particular service. It's not enough. So the healthcare industry is looking at, what are other ways where practices can, work towards bonuses and incentives. As Dr. Bradley alluded to earlier, shared savings. And that's what value-based contracting is. It's basically looking at adding some additional measures, quality measures, that practices can work towards to earn extra money. Those quality measures could include preventative items such as breast cancer screening, cervical cancer screening, even simple labs needed for those that have diabetes, and rewarding the practices for meeting those specific goals and keeping those tests, in place year to year. So MedNet has gotten into this space.
Well, the way I see it is if you do well as a physician, you meet all the bullet points, you take care of your necessary screening tests for the patients, you hit all the bullets that you have to do to keep that patient healthy, you save the state money, you save the feds money, they in turn give you a bonus probably at the end of the year saying that you did a good job and congratulations and here's a bonus.
Yes, that is correct. And something that the practices don't have, unfortunately, is time. And so that is another value add that MedNet offers to practices, as just being part of general membership, no additional fees around that. We will help the practices with their value-based contracting. We will help them by providing dashboard reporting for where they stand with quality measures. We've even hired a registered nurse that acts as a care coordinator that we offer practices to use to call patients that need to come in for certain tests or labs. And we offer a lot of services. A lot of folks in our industry charge for those services under the value-based side, and then the practices are getting less money at the end of a given year. So I think that's something that sets us apart.
Are you similar to an accountable care organization?
We are.
Yes, you are.
Mm-hmm. We also
accountable care organization is an ACO. You might have heard that term, and this is where they do the collection of data, analysis of the data, and tell you if you've met all the standards needed to get your bonus. Correct?
Correct.
Okay.
We're also considered what they call a clinically integrated network, or a CIN, and that means exactly how it sounds. We are integrated in the sense that we're collecting data from multiple payers. We're working with multiple practices on their particular data, how they're performing on quality measures, and we're doing something about it. One thing I do want to mention as it relates to the value-based contracting and the quality measures is we are partnering on a pilot project with the state's Health Information Exchange, the Delaware Health Information Network, or the DHIN, to try to help add more value to closing what they call care gaps and doing better with quality measures by using the network of the DHIN to kind of support some of our processes.
And you actually have registered nurses who may contact patients and say, hey, you're due for a mammogram. Hey, you're due for a pap smear and A1C if you're a diabetic, etc. Is that true?
Yes, we do have one registered nurse that helps in that capacity.
Good. Is she busy?
She's very busy.
Yes,
I'd just like to add that, a lot of our practices are, 1, 2, 3 doctor practices there. Dover Family Physicians, we had 7 doctors and 2 PAs and a staff that really could go out and do those care gap closures. A lot of the smaller practices can't afford to hire a nurse to call patients, on a daily basis to remind them, you're due for your colonoscopy. Why did you go to the ER yesterday when you could have called us? Mm-hmm. You just got released from the hospital. We need to see you. Those kind of care gap things really are provided or can be provided through our MedNet network.
Another great benefit of MedNet. Okay.
I would also like to add, since you brought up accountable care organizations, or ACOs, and I mentioned clinically integrated networks, or CINs, the Delaware market's very competitive in this space. For such a small state, we have anywhere from 6 to 8 different ACOs or CINs trying to perform the same services for the same groups of physicians and or hospitals, health systems. So you may say, well, what's different about MedNet then? Why,
What is different?
It's very different. First of all, we are a trusted organization owned by the Medical Society of Delaware. That carries a ton of weight. As Dr. Bradley mentioned earlier, the way that we're structured, we're physician-led, physician-owned, physician-run, and that speaks volumes as it relates to trust, reputation. Also, a lot of other ACOs or CINs in the Delaware region, like I mentioned earlier, they charge you, for certain services, or they'll retain a pretty significant percentage of whatever your bonus is at the end of the year. With MedNet, we're just covering our costs, so we're looking at maybe 10 to 20% of retainment of those types of bonuses, so that the physician practices are getting 80-90% of that money, which is well deserved. And then finally, I will say that we have such minimal membership dues, not even worthy of talking about the amount. They're so low per year for membership. And again, that's just to help with operational costs, but that definitely sets us apart in the market.
Talk to me about the overall success of the program. It's been around a long time.
Yes, it's been around a long time, but as far as the value-based component, we entered into this space in 2018 with one of the largest Medicaid plans in Delaware. We have met incentive or shared savings year over year very consistently, and each year we improve our overall quality scores. So we're headed in the right direction. We had landed our first commercial value-based contract in 2023. So we're working in the commercial space in addition to Medicaid. And we're looking to bring on 2 additional contracts, hopefully in 2026, to expand our reach.
Now, my question to you is, if you belong to a different ACO, you can still utilize MedNet's advantages, correct, or can you?
Absolutely. So if you're a part of another ACO or clinically integrated network, and you're interested in our fee-for-service contracts, you can come on board for just those. It won't interrupt any of your services that you're doing with another organization. If you're interested in switching your value-based contracting to MedNet, you can certainly do that as well. This is something that Dr. Bradley was talking about, opt-in. We leave it up to the practices on how much or how little they want to participate.
So if you get shared savings because you've done such a good job, you guys only retain a small percentage of the gains that came in, where other ACOs charge percentage much higher. Is that correct?
Yes. What we've heard in some cases is that some other organizations may only share 40 or 50% of the savings earned or incentives earned. And some also may charge management fees for some of the services that we include automatically.
Gotcha. I think with all the benefits you get from this, discuss the fee. It's very low.
It is.
And what is it?
Right now, for 2025, it is $125 per practitioner per year. That's all.
Okay. Very good. That's a reasonable price for what you can get out of it and what the services they offer. It seems that everybody that is a physician should join, and I do not know why they don't, if they don't. Maybe they're not aware of all the benefits, and that would be a way to hopefully get this podcast out to these guys and say, join up. We're making very strong efforts through MedNet and other organizations to enhance primary care reform. As you know, and I've talked about this in previous podcasts, the foundation of medicine is starting to crumble because the foundation of medicine is based upon primary care, without a doubt, and that's been proven. I'd like to ask you, Mike, what's wrong with our system? Why can't we see enhanced reimbursement for primary care to keep them in business? The more students I teach, the less I see going into primary care. They're all going into something, and they say, Doc, I would love to possibly, and I've had students who would be great primary care doctors just by the way they communicate with my patients, and yet they say, Doc, I come out of med school with $250,000, $300,000 in debt, and at your reimbursement fees, it would be $60,000 till I pay it off. So I see their point, but in turn, it's hurting the foundation of medicine. Mike, what do you think?
I agree with you totally. In my family practice program in the Army, we had physicians who were fully trained to do 90% of what a patient needs, during. So when we come out of practice now, I think physicians in primary care are probably not being taught as much as they used to be because of the fragmentation of the medical system. So we have so many subspecialists that patients are happy to see their cardiologist for a blood pressure check and rarely going to their primary care physician where they should be going.
That's cool. The
main thing about reimbursement for primary care physicians is that we're probably the bottom of the barrel. Mm-hmm. Primary care is not being reimbursed enough for the amount of work that we really do to keep our patients healthy.
I agree with you.
The state of Delaware is probably in the lower third, if not further on, in reimbursement. The amount of money that the state is paying for primary care services had been running around 45% of the total cost of care in Delaware. The states that are at the forefront, like New Hampshire, Oregon, Washington, Vermont, are paying upwards of 15% of their health care costs for primary care, because their studies have been shown that for every extra dollar you put into primary care, you're going to save $2 to $3 in the long run.
I thought that number was higher, but go ahead.
Very well. We'll bring in Dr. Gill sometime.
Yeah, he has all that data.
So I think the reimbursement has been noted by the state. Why can't we retain enough or produce enough primary care doctors to stay in Delaware? It's mainly for the cost. They can go into a subspecialty or go to another state that pays higher for primary care services than we do here. So I'm trying to think. Probably it was about 5 or 6 years ago that the state came up with the primary care reform collaboration. Mm-hmm. It was a roundtable discussion. All the insurance companies, all the state payers, all the hospitals were there. There were a number of primary care physicians. There were nurses groups. This was a roundtable of about 30 persons, and we got together and looked at what can we do to retain and increase primary care services in Delaware. Well, that process has now been in probably 5 years. We had the passage of Senate Bill 120, which mandated that the state would improve primary care reimbursement to a certain level. I think working up towards 12% of total cost of care. Mm-hmm. Unfortunately, the state only has control over about 10% of the commercially insured patients.
Correct.
The other 90% are either in ERISA waived large employers who don't have to follow state regulations, Medicaid, and the state health employees. Mm-hmm. So we've been beating our head against the wall trying to improve primary care reimbursement for this 10% of the population. And the hospitals have not been as cooperative as we liked. The insurance companies all initially said, sounds like a great idea, Mike, let's do it. And they haven't done anything.
Right.
So we're at a point where the number of primary care physicians leaving the state or retiring or going concierge practice like you, mm-hmm. they're not being replaced at enough levels. So what's happening also is that hospitals are buying up primary care practices.
Correct.
Those physicians in those practices are getting a nice salary, but all of the funds are going into the hospital. So we think that some of the primary care reimbursement that the state is mandating from the insurance companies is going to the hospital and not feeding down into the individual primary care practice.
I agree with you 100%. This and all of this is contributing to our workforce shortage. Mm-hmm. We don't have enough primary care doctors. None of them want to go into it. We're not being reimbursed. And during the Obama administration, when he said that nurse practitioners are allowed to hang a shingle, that was kind of a smack in our face as primary care doctors, because after we complete our training of some 26,000 hours, that includes residency, and they complete theirs at 5,000 hours in training, kind of who would you want to go see? I think the higher trained person would be the one I would. And what happened to us is that many of the functions of the primary care doctor are being taken over by nurse practitioners. They have a place, but not an independent place. They should be under a physician, and that's what I feel. That's my personal belief. I may get a lot of feedback on this, but it's just the way I feel. Mm-hmm. Because studies have shown that the cost under a nurse practitioner may be higher than seeing a primary care physician. Okay, and then here we have all of these administrative burdens that doctors say, I don't want to be involved with that baloney. I'll go work for a hospital, let them do all that, and pay me a salary. I punch in my 8 hours and I go home. Mm-hmm. Well, they work them like dogs, I hear. I mean, I don't work for a hospital, but I hear they work them like dogs. So I guess they can take that or leave it. And then if you screw up because patients don't want to comply, you get as a primary care physician penalized. Mm-hmm. Not fair.
Every insurance company now has a set of quality measures. We're calling it a report card. How the individual practice is doing. But I can't control my patients who want to see their cardiologist, their pulmonary doctor, all the subspecialties that are available to them that I have absolutely no control over.
Right.
I don't have a control over the testing that they do. But as the primary care doctor, it seems that most of the insurance companies are looking at our report cards and saying how much extra money per member per year that we're spending when I have no control over that. The other thing that I've really brought forward at the Primary Care Commission is the fact that probably somewhere 5-6 years ago, the state allows all Medicaid patients to walk into the ER or walk into a doc-in-the-box walk-in clinic without a referral from their primary care physician. Way back when MedNet became the provider of Medicaid services to the state, every patient in Medicaid had a primary care doctor assigned to them, and they still do today. But we have no control over their ability, and the state pays for it, for them to walk into a walk-in-the-box clinic for a sore throat or an earache. Minor things that we can take care of in our office at a much lower cost.
I agree, but to be fair, some physicians, it may take 3-4 weeks till they could get to see them. That's because they're so overwhelmed with their practice that they can't fit them in.
Right.
So that's another problem. I think we need federal action on this. I don't know why they cannot get rid of the ERISA plan, which seems to inhibit a lot of states from taking action to help primary care doctors within their state.
Yeah. I think that was set up at the federal level for companies that were multi-state, so that they only had to follow federal guidelines rather than each individual state coming up with their own regulations. And I can see it from their standpoint. Back when Obama promulgated the Affordable Care Act, one of their things was that they were going to allow interstate purchase of insurance, so that here in Delaware, I could purchase insurance from Maryland or New Jersey or Oklahoma that would pay for care here in Delaware, so that we have such a small population, 1 million, that insurance companies have a hard time making enough money for their owners and such. So, that part of the Affordable Care Act failed because
yes, it does not occur.
It does not occur today. So we're left with trying to bring in new insurance companies in Delaware for a small piece of the pie.
And they're not interested.
They're not interested. 25% of the patients in Delaware are on Medicaid, which is a federal program. The state can ask for a waiver, and I think that's part of what the Department of Insurance is looking at the present time, coming up with a waiver so that they can put those patients into the SB 120 plan. They're also talking about bringing in the state health employees. If they could bring in those two groups to the 10% we have right now, that would bring over 50% of the population into the workings of Senate Bill 120, which would make things a lot better for primary care physicians.
And be more attractive to the outside insurers. And allowing us to buy insurance across state lines would provide competition, which would lower premiums. And that's just a given. So this is some of the things that we should be working on, and we have been tirelessly working on it at our state legislature, and I think this has to continue. Are there any other things you would like to point out? If not, I would love to get the information out there on how you get more information about MedNet and who to call or email, so that if they haven't joined, they can. Lorianne, you probably know that pretty well.
Absolutely. I would like to offer our email address to MedNet, which is mednet, MEDNET, at medsocdel.org, which is medsocdel.org. Our phone number is 302-224-5182, and we welcome calls for information. We hope that other practices will consider joining.
Very good. Well, this has been one interesting discussion about MedNet. I am a member. I'm the president of the Newcastle County PO. I know all about what's going on. I think we have a great organization. I think we have much more of a potential than we're tapping into if things should change, i.e., can we get more people involved? physician-wise, can we have primary care get boosted on their income? And with some of these things you mentioned, that we may get 50% of those in the state somewhat under the control of the insurers here in the state, we can benefit from that itself. Okay, this is Dr. Nick Biasotto with ending our great discussion between Dr. Michael Bradley and Lorianne Rhoads about MedNet. If you do not belong, it's very advisable that you do. Until next time.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Minton. For the Medical Society of Delaware, I'm Lorianne Rhoads. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the host or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.